Hello, I'm Professor Jonathan Barratt, and it's a real pleasure to join you at the Indian Society of Nephrology meeting, and I'd like to thank the organisers for asking me to talk today on emerging therapies in IgA nephropathy. So I've got about 20 minutes to take you through what's happening at the moment across the globe in terms of new therapies. I'm going to switch my camera off now so you can concentrate on the slides, but I hope you enjoy the talk, and I look forward to hearing your questions at the end of my presentation. So IgA nephropathy is the most common form of primary glomerulonephritis, with up to 50% of patients developing end-stage kidney disease in their lifetime. It's estimated that 10% of the global dialysis population have developed end-stage kidney disease because of IgA nephropathy. And while kidney transplantation is the preferred option for those who develop end-stage kidney disease, a large number will develop recurrent disease, which puts them at risk of graft loss. As you can see, the global burden of IgA nephropathy is significant, and more so in East and Southeast Asia. But despite this global burden of disease, in 2021 there are still no approved therapies for the treatment of IgA nephropathy. And if I was giving this talk some 5 or 10 years ago, this is where I would stop, because actually no one was interested in studying IgA nephropathy for new therapies, despite it being the commonest global glomerulonephritis. So why is that? Well, we all know that IgA nephropathy is a rare disease and it is slowly progressive. And so if we were to try and study a new therapy and look for drug efficacy using traditional endpoints as kidney failure or even halving of GFR, we would have to follow a very large number of patients over a very long period of time before we would know whether a drug was safe and effective. And quite frankly, that's prohibitively expensive and a massive disincentive for the pharmaceutical industry. But that recently changed. And that changed following this initiative from the Kidney Health Initiative, which wanted to look at surrogate endpoints which could be used in clinical trials of IgA nephropathy. And we published a white paper, and the essential high-level output from that paper was that we can use an early change in proteinuria between 6 and 12 months after starting a new therapy to evaluate efficacy. And as you can see on the graph on the left here, where we're looking at a treatment effect on proteinuria on the horizontal axis, and the hazard ratio for a clinical endpoint here, which was a doubling of serum creatinine, end-stage kidney disease or death, with a greater reduction in proteinuria, you see a greater reduction in the hazard ratio for an event. So what we're seeing here is if we reduce the proteinuria with a treatment by 35%, so a value of 0.65 here, we are able to almost halve the hazard ratio for a doubling of serum creatinine end-stage kidney disease or death. And this has led the FDA to agree that an early change in proteinuria is a reasonably likely surrogate for long-term kidney protection. And this has revolutionized the clinical trial landscape. And we now have 5 phase 3 registration studies ongoing in IgA nephropathy and many phase 2 studies of novel therapies, because now the drug industry can affordably invest in IgA nephropathy research with trials that are smaller, shorter duration, and will yield results at relatively minimal expense compared to what we were looking at when we had to use end-stage kidney disease or a halving of GFR. And so what I'm going to do now is I'm going to talk you through those new agents, but before I do that, I just want to go over at a high level what we understand by the pathogenesis of IgA nephropathy. So we believe the major driver for IgA nephropathy is the formation of circulating immune complexes, which are prone to deposit within the kidneys where they trigger inflammation and scarring. And we think the major substrate for that immune complex formation are these poorly galactosylated polymeric IgA1 molecules that have this very distinctive change in the O-linked glycans at the hinge region of the IgA1 molecule. We believe these IgA molecules are derived from the mucosal immune system, so the immune system that lines our respiratory tract, our gut, and our genitourinary system. We think that these immune complexes form through a variety of processes, but we know that this polymeric poorly galactosylated IgA is capable of aggregating by itself and forming immune complexes, but this process can be amplified by the presence of IgG and IgA1 autoantibodies to the IgA1 hinge region. And of course, all of these processes occur on a genetic background. A genetic background that not only increases the likelihood of an individual developing IgA nephropathy, but also once they have an IgA nephropathy, the genetic background could influence how quickly that patient progresses to kidney failure. And we're just starting to tease out what those genetic factors might be. And when we think about what happens when IgA immune complexes deposit within the kidneys, we see that this mesangial IgA deposition leads to mesangial cell proliferation, the release of pro-inflammatory and pro-fibrotic mediators that can recruit into the glomerulus other inflammatory cells, principally monocyte macrophages. That inflammation can be so severe that we get crescent formation. We don't see that very often, but it can occur. We also know that these pro-inflammatory and pro-fibrotic mediators can cross the glomerular basement membrane and come into contact with podocytes, promoting podocyte injury and glomerular sclerosis. And they can come into contact with tubular epithelial cells where they can cause phenotypic transformation, resulting in a pro-inflammatory and pro-fibrotic phenotype, driving tubulointerstitial fibrosis. And what's becoming increasingly recognised is that filtration of the IgA immune complexes across a damaged glomerular basement membrane can also lead to direct actions on both podocytes and tubular epithelial cells. And of course, all of these processes can be amplified by the co-activation of complement. And I'll come on to that later in my talk. And so I'm sure you all recognise the standard of care for all patients with IgA nephropathy is to block the renin-angiotensin system. And we've known the importance of this system in driving kidney scarring for all proteinuric kidney diseases for many, many years. But what's become apparent over the last decade or so is that in parallel with the renin-angiotensin system, there is also an endothelin system. And as you can see here, endothelin 1 acting through the endothelin receptors is capable of driving within the glomerulus both inflammation, angiogenesis, cell growth and proliferation, but also has an effect on the hemodynamics of the glomerulus, altering blood flow through the glomerulus in a synergistic way to angiotensin II. And we know from early studies from a range of kidney diseases that blocking endothelin receptor activation is capable of impacting but not only on proteinuria, but also on future rates of kidney function decline. And so these drugs are potentially useful additions to renin-angiotensin system blockade. And indeed, this is being evaluated at the moment in the PROTECT study, which is evaluating the drug sparsentan in IgA nephropathy. Now, sparsentan is an interesting drug because it has two modes of action in one. It has an endothelin receptor antagonist action, but it is also an angiotensin receptor blocker. And therefore, this drug both blocks the renin-angiotensin system, but also the endothelin system. We have some initial data in FSGS from the DUET study showing an antiproteinuric effect. And this is now being tested again in FSGS in the DUPLEX study. And we have the data that is starting to be generated from the PROTECT study. Now, we have the 9-month proteinuria data from this study, only released as a press release by the company, but this reports a 50% reduction in proteinuria after 9 months treatment with sparsentan, which is pretty impressive. We need to wait for the full data to be able to know how this drug works over the longer time period and what associated adverse events there are with this treatment, but it looks like endothelin receptor antagonism may well be one of the things that we will want to do for our patients in the future. Sparsentan isn't the only endothelin receptor antagonist currently being evaluated. We have atrasentan, which is a endothelin receptor antagonist but does not have the angiotensin receptor blocking action, and so can be combined with any ARB or RAS inhibitor of your choice. This study is currently recruiting, and bearing in mind the great results that have been seen with sparsentan, I would imagine that this study is going to recruit well and will be interesting and confirmatory evidence for the value of endothelin receptor antagonism in IgA nephropathy. As I mentioned, we think the mucosal immune system is the source for these pathogenic IgA molecules that form immune complexes. And indeed, we've known about an association between the mucosal immune system and IgA nephropathy really since the first description of IgA nephropathy. Indeed, I'm sure we've all seen patients who present with visible hematuria 48 hours after picking up a cough or a cold, And that's often the presenting feature in particularly young adult males for IgA nephropathy, certainly in my practice. So we've known from a variety of sources that there is a very clear link between the mucosal immune system and the development of nephritis and the development of pathogenic IgA molecules in IgA nephropathy. And indeed, there's been intense focus on the mucosal-associated lymphoid tissue as the source of pathogenic IgA. And indeed, in studies that we've done, we've shown that IgA generated within the mucosal immune system is predominantly polymeric, IgA1, and carries those sugar changes at the hinge region that we see in the IgA deposits. And so there's a lot of evidence supporting the mucosal associated lymphoid tissue as being the source of this pathogenic IgA. And indeed, when we look at the genetic data, and here we published the largest meta-GWAS in IgA nephropathy, we can see that when we look at the pathway analysis, looking at where those genetic risk alleles congregate in terms of the pathways that they drive, we can see the predominant pathway was the intestinal immune network for IgA production, again supporting the mucosal immune system as the source of pathogenic IgA in IgA nephropathy. And so it makes complete sense to consider, why don't we target a drug to the mucosal immune system to see if we can switch off pathogenic IgA production and therefore prevent immune complex formation, IgA deposition, and glomerulonephritis. And indeed, there is a drug that's designed to do that. This drug is called Nefecon. It is a specific formulation of the steroid budesonide that is packaged in such a way that the steroid is only released in the distal ileum with very little systemic absorption. And the reason it's targeted at the distal ileum is because it's this part of the bowel that contains the highest, most concentrated level of IgA producing immune cells. And these are found within specialized lymphoid follicles called Peyer's patches, which you can see here on the right hand side. And so targeting this drug to that area of the gastrointestinal tract with the greatest concentration of IgA producing cells has been a rationale for Nefecon's use in IgA nephropathy. A phase 2 study was performed, the Nefegan study of 150 patients, and in this phase 2 study we saw that 16 milligrams of budesonide, of Nefecon, generated a significant reduction in proteinuria at 9 months and preserved GFR over 12 months. So exciting initial data, which is noted in the phase 3 Nefigard study. And so I presented the 9-month proteinuria data and GFR data at the World Congress earlier this year. And what you can see in this slide is that on the left-hand side of each panel is the data from the phase 2 study, and on the right-hand side is data from the Nefigard study. And if you look at the top right panel, you can see that Nefecon consistently produces a significant reduction in proteinuria at 9 months. You can see this equates to around 30% and is remarkably similar between the phase 2 and the phase 3. Not surprisingly, there was a parallel reduction in albuminuria, and most importantly, we saw a protection in GFR at 9 months. So we saw a reduction in GFR in the placebo group, as you might expect, because these studies recruited high-risk patients. And so you saw a decline of around 4 mils per minute per year in the placebo group, but there was no decline in GFR in the Nefigard treated group. And so this is really exciting evidence that actually this drug can not only reduce proteinuria, but can also protect against GFR decline. Now we need to wait for the 2-year data to be absolutely sure on the GFR outcomes, but this is, in my view, exciting data, and this data is with the FDA at the moment, and we are expecting a decision on approval of this drug for the treatment of IgA nephropathy within the next 2 weeks. And so we could be looking at data that will support the first ever drug approved to treat IgA nephropathy. We know that IgA and the antibodies against IgA are produced by plasma cells, and so why not direct a treatment towards B cells and B cell development into plasma cells? And we know the agent that we would normally use in that situation is rituximab, and indeed that has been tried in IgA nephropathy. But unfortunately it failed to have any effect, despite effectively depleting B cells in the periphery. There was no impact on these abnormal IgA molecules, no impact on the IgA autoantibodies, and no impact on proteinuria or GFR. So does that mean a B cell approach is not appropriate in IgA nephropathy? Well, actually, B cells require a number of signals to survive, to differentiate, to class switch. And two of those key signals are BAFF and APRIL, which act through a series of cell surface receptors that you can see here, the principal two being TACI and BCMA. We know that there's dysregulation of BAFF signaling in IgA nephropathy from a variety of sources. Similarly, we know there is dysregulation of APRIL signaling. And so these make highly plausible targets when we're thinking about reducing pathogenic IgA production in IgA nephropathy. And indeed, there are a range of drugs that have been developed to block BAFF and APRIL signaling. We have drugs that only block BAFF signaling, such as belimumab, and you may know that this drug has recently been approved for the treatment of lupus nephritis. We have drugs that target both BAFF and APRIL, and here we have atacicept. And then we have drugs that just target APRIL. And we've got two monoclonal antibodies that are currently in development that do that. And so a number of these are currently being evaluated in IgA nephropathy. I presented data on atacicept last year at the ERA conference, and what is striking about this data is that by targeting BAFF and APRIL, you are able to significantly reduce the levels of abnormally glycosylated IgA, Gd-IgA1. And what you can see here is that 75 milligrams of atacicept reduced Gd-IgA1 levels by over 60%. This is unprecedented. We've not had a drug previously that was capable of reducing Gd-IgA1 to that extent. And you can see that that translated through to significant reduction in proteinuria. Now, the caveat here is this is an early data. It is small numbers of patients, but this is being validated in the follow-on phase 2 study called the Origin study. And this is going to be recruiting in India, so I hope you're aware of it, and if you're interested in being involved, please let me know. And here we're going to actually test a higher dose of atacicept, 150 milligrams as well. So exciting that we're able to suppress Gd-IgA1 to such an extent, and the idea is that that will then translate through to reduced immune complex formation and protection of the kidney from IgA deposition. Vistera have a monoclonal antibody that is APRIL only, VIS649. This is currently in phase 2 and again is recruiting in India. So I hope that you're aware of this and potentially looking for patients for this study. We don't have any data on VIS649 yet, but this study will hopefully be finished recruiting in the very near future. Chinook have their own anti-APRIL monoclonal antibody. It's currently being evaluated in a phase 1-2 study, and I presented some early results in IgA nephropathy. And again, with this approach, you again see a significant reduction in Gd-IgA1. Again, small numbers, and this reduction in Gd-IgA1 appears to translate through to reductions in proteinuria. So I think this BAFF-APRIL axis is going to be something to watch out for in the future as a really viable option in terms of targeting pathogenic IgA production in IgA nephropathy. So coming on now to complement activation. So complement activation amplifies all of the negative consequences of IgA deposition in the kidney. We know it's present in over 95% of cases of IgA nephropathy and has always been an aspiration to target, but we've never had a drug able to do it. We know that complement activation is present and linked to worse outcome from studies from both blood, urine, and from kidney biopsy studies. And with eculizumab, we now have developed proof of concept data that targeting complement activation can impact on long-term outcome in IgA nephropathy from these isolated case studies. And so this has been the main trigger to look at complement therapies. You'll all recognize this complement cascade, and one of the drugs that's currently being evaluated is a drug that targets C5 production in the liver called cemdisiran. This is a really interesting drug because it's an antisense oligonucleotide designed to be taken up by liver cells and to gene silence essentially the production of C5 within the liver and therefore reduce C5 delivery to the kidneys. Another drug targeting the C5 axis is avacopan. It's been used in a small number of patients to date with some interesting early results, but they've only been presented in abstract form. We know avacopan has now been approved for the treatment of ANCA-associated vasculitis, and it may well be that we may be thinking about using avacopan in the future for IgA nephropathy as well, but we need more data on this drug. We could target C3 production with pegcetacoplan. This agent has been looked at in IgA nephropathy in a small basket trial, but we've seen no data in IgA nephropathy at the moment, and we just need to wait and see what that data might show as to whether this is a viable strategy. We do actually have more data on targeting the lectin pathway, and we know that activation of the lectin pathway is associated with a worse outcome in IgA disease. And indeed, we've published some early phase 2 data on the use of narsoplimab, a specific antibody against MASP2, the key protease of the lectin pathway, showing quite substantial reductions in proteinuria and long-term kidney function survival. And indeed, we presented the long-term data at the ASN last month. And so narsoplimab currently being evaluated in a global phase 3 study, the Artemis IgAN study. And again, I believe this study will be coming to India if it's not there already. So again, please look out for this, because it would be great to have Indian patients in this study. In terms of the alternative pathway, again, lots of evidence to support alternative pathway activation, driving glomerular injury and worse outcomes in IgA nephropathy, both from kidney biopsy studies, but also from genetic studies. A number of agents that can target alternative pathway activation. We have small molecule inhibitors of factor D and factor B, and those agents that are currently being studied in IgA nephropathy include iptacopan and Ionis, FB-LRX. Both of these target factor B, a key factor within the alternative pathway. In terms of iptacopan, I presented data at the ERA meeting this year on the first few patients that have been treated with this agent, and what we saw was a clear dose-dependent reduction in proteinuria out to 90 days with iptacopan. Really exciting data that tells us that blocking the alternative pathway is likely to be beneficial in IgA nephropathy. And perhaps even more interesting is this panel at the bottom right, where we looked at soluble C5 beta 9 in the urine, so the terminal complement complex, and showed that iptacopan was capable of suppressing the excretion of this complement compound in the urine, suggesting that this drug is actually impacting on complement activation within the kidneys, which is exactly what we want it to do. So this early data has supported the delivery of a phase 3 global study of iptacopan in IgA nephropathy, the Applause IgAN study. And again, I think this study is recruiting in India, so please bear this in mind when you are looking after patients and seeing patients in your clinics. The Ionis compound is much earlier in development and is actually another antisense oligonucleotide. I've not seen any data for this yet, but again, an exciting move forward in terms of molecular approaches to the treatment of IgA nephropathy. And so where are we going to be in the next 10 years? Well, I hope I've convinced you that the future is going to be exciting. We are going to have multiple therapies, and it may give us the opportunity to target specific therapies to specific patients at the right time for the right patient, with the patient having therapies directed to the pathogenic pathways that are operating at that moment in time. We're going to have access to non-immune therapies such as endothelin receptor antagonism. I'm sure we may get some questions in the Q&A session about SGLT2 inhibitors. There's some interesting early data on those as well. And then we're going to be able to target specifically the pathogenic cascade in IgA nephropathy, either through targeting B cells directly with a BAFF-APRIL approach or the mucosal immune system. And then, of course, we'll be able to have a significant anti-inflammatory effect by switching off complement. So I'm going to finish there. I look forward to discussions, and thank you for your attention.